Okay, to all who are new here, my name is Dr. Michelle Henny. I would like to welcome you to Relevé Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or you can sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Relevé Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by Relevé Sports Medicine or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the website. Relevé Sports Medicine hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content which is provided as is and without warranties. We are looking for an athletic trainer to join our team. This is a combined position working in a sports medicine clinic and in a university role. Please feel free to pass our information along if you know of a qualified candidate. More information regarding applying can be found on our website. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevésportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Our speaker this evening is Dr. Melissa Nicoletti. She received her undergraduate degree from Clemson University and her medical degree from Trinity School of Medicine in St. Vincent. She completed her residency in family medicine at Franklin Square Hospital in Baltimore, Maryland, and subsequently resided in Maui, where she worked at a local urgent care and covered various water sports events. Due to her love of sports and desire to educate herself further in the sports medicine world, she relocated to Miami, where she recently completed her sports medicine fellowship at Miami Orthopedics and Sports Medicine Institute. During her training, she had the opportunity to cover various teams and events, including Florida International University football and Women's Basketball Conference USA Championships, St. Thomas University, Barry University, Miami Open, Miami Dolphins, and the Fort Lauderdale CF team. Prior to her medical career, Dr. Nicoletti was employed in real estate and had the unique opportunity to train Dolphins for the U.S. Navy in San Diego. She also has a black belt in Tae Kwon Do. We are so thrilled that she recently joined the team at Relevé Sports Medicine, and we are happy to have her. She will be speaking tonight on relative energy deficiency in sport, and I'm going to go ahead and let her take it away.
Thank you, Dr. Henning. I appreciate that introduction. All right. Hello, everyone. Thank you for all being here. I am going to log into my presentation and get started. You all see my screen. I just want to make sure. Hopefully you can all see it. If you can't, just write something on the chat. I did share it. Okay. All right. All right. So we all used to know this as the female athlete triad, but the name that came out recently, a couple of years ago, is Relative Energy Deficiency in Sports. So I'm going to go into a little detail of what that is, what to look for. But let's start out. First, I do not have any relevant financial relationship or commercial interest, no conflict of interest. So some of the objectives. So I'd like to describe the basic concepts and the definitions needing and understanding the triad. To define RED-S and the newest IOC updates released in BJSM in 2018. To discuss the screening tools used to make the diagnosis. To discuss when further testing should be used, including a Dexa scan, which I'll go into a little detail of that. And to discuss the approaches to treating. And lastly, and I feel this is the most important, to raise awareness of RED-S to medical teams treating athletes, which is the vast majority of you all signed on right now. So in 1992, the ACSM introduced this term, the female athlete triad, just to describe a phenomenon of physically active women who have either disordered eating, but they don't necessarily have to have an eating disorder, and amenorrhea and osteoporosis. So in the International Olympic Committee defined RED-S in 2014. So what exactly is that? It results from decreased energy availability due to low caloric intake and excessive energy expenditure. So defined. The definition that was put out by the IOC is it's an impaired physiologic functioning caused by relative energy deficiency and includes but is not limited to impairments of metabolic rate, menstrual function for females, bone health, immunity, protein synthesis, and cardiovascular health. So essentially saying that it can cripple the performance in women, but also men athletes, and it occurs unknowingly, not necessarily with an eating disorder. So the two of them combined, it was adapted from the previously known concept, as I said before, the female athlete triad, but it is no longer a triad because you don't necessarily have to have the menstrual dysfunction. So it's not just female, it is also found in males. There is data now that suggests a parallel syndrome that does affect undernourished males, and it can cause hypogonadotropic hypogonadism, result in bone health impairment. So, for example, making weight if they have inadequate energy intake in a high endurance sport. So it doesn't necessarily have to be something that they're consciously making an effort to not have the energy that they're taking in. And then also a desire to build muscles. So it's a newer model, and the main focus is this low energy availability. So we're going to go into a little bit of the IOC update that is now in 2018, the newest update that we have. The ACSM position statement. So at the top, you'll see the most important are the two grades, the grade A. So we know that severe undernutrition impairs reproductive and skeletal health. And then disordered eating or eating disorders and amenorrhea can occur more frequently in sports that emphasize leanness. And then you'll also see where menstrual irregularities and low BMD do increase stress fracture risk. Those are all grade A. So this is just saying the position stand replaces the 1997 ACSM position stand, updating understanding, and that is not just about the triad anymore, and discussing treatments, because before we had talked about acknowledging what the triad is, but not going to any further steps for prevention and different forms of treatment that were non-pharmacologic. So if you go onto the ACSM website, you'll see the position stands, and there's a lot of different joint statements, but the female athlete triad is listed in the top 10. ACOG also came out with a committee opinion in 2017 regarding the female athlete triad. So I'm just going to go over a couple of cases, and then we'll come right back to them and talk about what went on after the fact. So first case is a 21-year-old female basketball player. She presented to the training room after her roommates were concerned about her eating habits and excessive working out after hours. This is an NCAA 2 collegiate athlete. She had recently lost weight. She changed her diet with significant limitations based on desire, not because of health reasons. And she, based on what her roommates said, it was a lot of the imaging, she was driven by social media likes to change her diet. So at this particular university, there was a Triad screening questionnaire that was handed out to all females. So this female had filled this screen out in September 2020, and it asked what her weight was. So the weight of that day in September was 138. A year ago, it was 150, and she still desired to drop a few more pounds. Now, the weight that she had at 138, she had dropped that in 3 months' time span from 150. So her BMI greater than 18.5. She's not taking any birth control. Last menstrual period was in May, so immediately that brings up a little bit of a red flag because we're doing this in September. Asking about menarche, because that is important at 15 or younger, which we'll go into. Any dietary restrictions, and yes, as you can see, she cut out lactose, salt, sugar, carbs, whole grains. No history of stress fractures, and the question number 8 can be a little difficult to get sometimes an honest answer. Have you ever had an eating disorder? Also, maybe not knowing exactly what an eating disorder is. So I was given this questionnaire and was asked to speak to the athlete during that time in September after completing it. So we'll go back to her. Another case is 18-year-old male surfer. So this surfer was a previously healthy pipeline surfer who came into my clinic. He was complaining of increasing fatigue, more irritable. He recently had a poor performance in his sport. He had a broken nose from a single episode on the board. So some of his vitals, 5'10", previously 169, he dropped down 152 in 2 months. I don't know if any of you are aware about different types of surfing, but he recently transitioned to a smaller board with a foil, so it's hydrofoiling. He found a lot of difficulty with it, and he assumed it was due to his weight and not this new apparatus that he was using, so restricted the weight, began intermittent fasting, primarily juicing. He began to have just some cramping, strains, and he just saw that his performance was quite poor as the past few months. So just real quick, if any of you, just a fun little video, don't know what hydrofoiling is, I just want to give you an example because I'm sure some of you have seen surfing. So as you can see, the board is a lot smaller, and it takes a lot different skill. This is not my athlete, that's Kylan. But okay, so to go into the female athlete triad model. So we see the red triangle there. You have the low energy availability, menstrual dysfunction, and low BMD. This is what we've known it as for some time. But what I want you to pay attention to is in the blue writing, the subclinical aspect of it. So you can have subclinical menstrual disorders. You can have lower BMD, but not enough that would be concerning or raise a red flag, and then just reduced energy in one fashion or another. So what is low energy availability? So essentially, with all of this put together to define it, it's just a mismatch between the energy intake, which is your diet, and the energy expended in exercise. So a few definitions I want to go over. So energy availability. So that's the daily amount of energy consumed in kilocalories minus the energy expended, and then it's divided by the fat-free mass. So fat-free mass is your total mass minus your fat mass. So obviously this has to be calculated by either a nutritionist or biometric scanning. Exercise energy expenditure is the energy expended during exercise in excess of the energy that would have been expended non-exercise. So it's that, think of it, that additional energy above your activities of daily living. So in healthy adults, you want to shoot for about 45 kilocalories per kilogram of the fat-free mass per day. So that is good energy balance. And this is in healthy, not sedentary adults, but we're not talking about athletes or even nearly elite athletes. So just an example, if you're getting less than 30, that's when you start to see the health disturbances. But there are a good bit of our athletes that sit at around 30, 45 range, where you might just see a little bit of weight loss or poor performance. So a few more. Disordered eating disorders. A lot of us know eating disorders defined by like bulimia and anorexia, but that is defined with the DSM-5 criteria. Disordered eating is abnormal fasting. And I know intermittent fasting has become quite a big thing, topic of discussion, but this is chronic intermittent fasting, or using laxatives or diet pills daily, enemas, that kind of stuff. So there was a study that was done showing the prevalence of this disordered eating among male collegiate athletes. It's just very interesting. If you look there, it says that athletes in the weight class sports report binge eating 2 to 3 times a month was 23%. So that's pretty high. And it is found that in those sports that require you to make weight is where we see it the most regarding weight control behaviors. So ligamentaria is when you have infrequent, irregular periods after 90 days without a period. Eumenorrhea is normal. Amenorrhea is there is no menstruation. So if you're talking about you haven't had a menstrual cycle by the age of 15, or the secondary is what you more apt to see with athletes, especially like my athlete who filled out that form for the Triad, when it was previously a regular menses, and then that has completely stopped for 3 months, or if they had irregular menses and then stopped for 6 months. So here's some health consequences of RED-S. You can see there's so many. We see the Triad is just filling in here where the menstrual function and bone health, but it goes well beyond that. And then the other performance deficiencies. So there are so many that we just, something just like irritability, impaired judgment. Now, just a quick note, a little background. So secondary amenorrhea can be caused by functional hypothalamic amenorrhea. So some of the risk factors to look for in that is anorexia, excessive exercise, and stress, which excessive exercise and stress come hand in hand a lot of the time with some of these, collegiate athletes, even athletes who are in high school and trying to get into a college as well. The anorexia is sometimes a little difficult to pinpoint, and we see a little bit more of bulimia with the binging and purging. Interesting is that healthy females achieve 92% of their total body mineral count by the age of 18. So the peak, though, is at 11 to 14, and that's when it is so important that they have the appropriate energy, because at that point, if they do not, then there's a concern for later on in life to have osteopenia or osteoporosis. So little diagram, I'm not going to go through this too much, but just to explain how it suppresses in the hypothalamus, and it diverts the energy from the reproductive systems because it's trying to get to the more vital organs. So reproductive system, not as vital. And that's why you're seeing this amenorrhea. And this is explaining it a little bit more in detail. I'm going to skip over this. So estrogen effects on bone. So think of osteoclasts are helping to resorb the bone, but osteoblasts build it. So you want to have this good balance. And if you don't have enough of either, that's when you get the osteoporosis and osteopenia, and that is usually from poor nutritional intake. Again, if you have this decreased estrogen that's leading to this amenorrhea, you have these other issues that can happen later. Now, granted, some of the athletes are not thinking of any of this, like infertility later on, but you see more on the other side, the mood disorders and the anxiety. And then once again, what that diagram showed, how it can begin just decrease glucose, and you have this inhibition that goes all the way to the end where you have amenorrhea, which again is you're not menstruating. So you want to get in the center here where you have adequate energy availability. As you can see on the insufficient energy intake, that can be from purposefully just restricting your diet, or on the other side, you can have excessive training load. So you're overtraining, but then you're also not taking in adequate nutrients. So that would be more unintentional. So here's an abstract about this low energy availability and the consequences of it. So this study took 1,000 female athletes aged 15 to 30 years old, and they had them complete an online questionnaire that defined them as having low energy availability or adequate. So here is a diagram. On the side of A, we're going to see more of the physical symptoms. On the side of B, and more performance driven. And there's a few red arrows that I put here, but what that's comparing, so if we look in A and we look at the cardiovascular, it's saying 3.98% versus 9.51. So 3.98% had stated in their questionnaire that they have adequate availability of energy. They're taking in, as you know, the adequate amount that was broken down in this test, but they still might have a few cardiovascular symptoms, maybe like some palpitations. 9.5% were saying, no, you know, I have a low percentage of it, and these are like the symptoms that I'm having. So if you go over to the other side in B, you can see there's decreased endurance performance. These numbers are going up, decreased training, impaired judgment, decreased coordination. It's usually at that point is when the athletes come to us. So it's not as much as like, oh, you know, I haven't menstruated in a little bit, and the hematological portion, they're really not going to know what their blood levels are, but it's the performance, because athletes are there to perform. They are there to be their best. Some are on scholarship, and some are there simply because they love the sport and it's all that they've done. So if their performance starts to become affected, that is when they're going to show up to all of you, to the athletic trainers, and start talking about it a little bit more. But by then, we're a little bit further along. So again, in this box here, it says this, so severe low energy availability, eating disorders such as anorexia, like I want just for everyone to know, which I'm sure they're well aware of, that later on, these can cause so many different cardiovascular changes, the bradycardia, hypertension, arrhythmias. But if we get to that point, then obviously they're not just pulled from their sport. There's so many other concerns. But prior to that, you're going to have the psychological aspects of it, which is the decreased, you know, training response. They're just irritable. They can't concentrate, whether it's in their sport and in school. And then that's going to affect their endurance. So just a little diagram of all the areas that are affected. So regarding eating disorders, so it is a challenge addressing this low energy availability, because it can be difficult to identify who has an eating disorder, who requires more comprehensive treatment, because most of the time they're not going to come to you and make you aware, especially if they're an athlete and their goal is to perform. So there's also denial and minimization. And those are very common themes in disordered eating and in eating disorders. So having the team physician working with the athletic trainers in a multidisciplinary team is the best way to find out the treatment approach individually for every athlete, because not every athlete is going to respond in the same manner. So once again, all these effects on the athletes. And then some endocrine consequences, which you have the decreased resting metabolic rate. So even if there is the disordered eating, Some athletes can also start to gain weight because their body is not utilizing their, glucose appropriately. You have decreased testosterone, so you can have both levels in male and females, which is going to affect performance as well. So who's at risk? Pretty much every athlete is at risk, but the big group of athletes that are the ones who have to make weight. We have the gymnasts who have to be a certain size, wrestlers, some boxers, martial arts, any combat sports, even para athletes try to make weight. And then jockeys. Jockeys is a big one because the smaller they are, the faster their horses can go, right? So another issue is just this increasing pressure to perform. There's a few quotes on here. One of them, Maddie Lawson had said, was just being hungry was a part of life. So it's been consistently put under the pressure for them to, yes, in order to perform, yes, you might have to be a little bit hungry. Even just drinking water is a fear of gaining weight. So the concern is the athletes at that time, and we're hoping that we're making a change with this, looked at food as an obstacle and not for performance. The Maddie Lawson was saying she took laxatives daily for 6 years. So just a quick mention again about para athletes. So they do have some of the anatomical sites that don't load bone as much. So as we know, walking and running help to build bone. But if you aren't able to do that, then you could potentially put you at risk of a lower bone mineral density for osteopenia. And then those athletes with spinal cord injuries, the ones in wheelchairs, potentially could restrict nutrients so they can maintain weight while they're performing. And then athletes with cerebral palsy, they have aberrant movements, so they have higher energy expenditure, and they have to make up for that and may not know necessarily how to get the right nutrients. So prevention. The main factor is we do need increased awareness among athletes, yes, but it's more so around their significant others, family members, coaches, everyone that's surrounding them, of that food is fuel, and that will help improve their performance, and to lead that discussion as a preventative measure and not at the point when we may potentially have to pull them from their sport to get them into a safer and healthier position. So in discussing body image, and then the other question is practices assessing body composition and weight. So we have here discussing body composition athletes and what do you do. Now, in the advanced, the elite level, there are assessments, their periodized approach, but these are typically more mature athletes with a positive self-body image. So you can talk more about doing different body composition. But if you look down at the foundation of the developing athletes, you don't really want to do those assessments. So you just want to make sure that they're growing optimally. They're within the percentile that they should be. They're not getting any stress fractures or burnout, and they're not specializing in their sport and what have you. So you don't want to necessarily focus on the composition at that point in time for performance, because that is when their bones are growing. That is, like I said before, their peak is 11 to 14 for bone growth. And we just want to make sure that we don't inhibit that at that age for any body shaming or having them be concerned. So some screening tools, similar to the tool that I showed you that my athlete had completed. These are some really good questions to ask. And sometimes you can incorporate that on the pre-participation physical. And then some things, not a lot you'll see on physical exams. So these are a little bit more on the extreme. Fatigue. Fatigue is a tough one because maybe they have really early morning practice. Maybe they have 2-a-days. They might have something else going on. So that's tough. You could have some hair loss. That could also be a thyroid condition. GI issues. They could have eaten something different or that didn't agree with them. You know, obviously, if you're seeing this extensive weight loss, that's a little different. That's going to jump out at you. You see the yellow hand, that's hyperkeratonemia. That's pretty advanced if you're seeing that. Parotid gland enlargement is pretty common in bulimia. Dental caries. Who doesn't have maybe a few dental caries? So that's kind of difficult. Calluses on the hands from induced vomiting. Bradycardia. If you're an elite athlete or you are collegiate level or what have you, I don't have bradycardia. Sleep disturbances. So as you can see, you can go through each of these and say, well, there could definitely be other reasons and it can be easily overlooked. Now, if they haven't had their menstruation, which I have encountered a few athletes when doing college level physicals that happened, and it hasn't been worked up, and they were told, well, it was told because I'm a track star, you know, it's normal for me not to get my period. Well, that's not. And then also what is important is asking the questions more so than doing the exam. So asking the menstrual history, asking if they have prior stress fractures or they're just recovering from one, and if they're on any birth control. You could do a whole panel of blood work as well. If you get a red flag and it's not kind of black and white of what exactly is going on. And then some specific labs. Other tests, you know, we do EKGs now. You'd have to be pretty extreme sinus bradycardia. You could see some other things that would alert you potentially. Again, talking about menstrual history. And then this is just a little diagram of other things that you could rule out. So after all the screening, you coming up with the diagnosis, it's not just by, you know, talking to the athlete via the team physician, but there's so many other people that are involved. The athletic trainers are around their athletes all the time. They know what their athlete is going through, whether they're going through something that day, part of their social life, what have you. They're the ones who are like boots to the ground and can kind of give you a feel as us, as the team physicians or mental health professional, or talking to the sports dietitian or the coaches on what is going on or if something is a little bit off. So I want to talk a little bit about BMD. So this just goes into the difference between premenopausal women, osteoporosis, and then children and adolescents. The biggest difference is asking about a significant fracture history. We're going to go into the scores, the TNZ score in a minute. So a few interventions. So how do you increase this low energy availability? Well, first thing, you got to reduce the training by at least 25%, unless we're at the point where they're having a stress fracture or there's something else that's concerning. At the same time you reduce the training, you need to increase their intake 200 to 600 calories at a time. And then following up every 1 to 2 weeks, seeing if they've gained weight. You know, we've had some where we put them on the weight, we don't let them see the number, and then continue with these restrictions. But if they're gaining, you can maybe reduce some of the exercise restriction, but continue to increase the caloric consumption for weight gain. And then an assessment of baseline energy. So some diet logs, maybe a dietary analysis program, having them do their own diary, making sure like you can measure their resting metabolic and exercise energy expenditure. So some drawbacks for that is that can be a little difficult, having them, you know, keep a food diary of what they're taking in and out. The different types of methods for body composition could be not very user friendly, and it's very time consuming. So step 2 would be using appropriate target for energy availability, such as meal plans, goals, achieving adequate calcium, vitamin D, iron, drinking fortified milks. So lean mass has been reported to be a strong predictor of hip bone mineral density among anorexic adolescents. And then also here is saying that there is a % change in fat-free mass, a significant positive predictor in the change in hip and lumbar spine, BMD. So changing that fat-free mass helps to take a few steps back if there is a concern for low BMD. And there are concerns that high impact activity in females with a low BMD can result in fracture, which we know. You have a low bone mineral density, that is concerning. And again, 26% of final bone mass is acquired between age 11.5 to 13.5 in girls and 13 to 15 in boys. So we got to catch it, but far beyond the time that they're in high school and college. So how long does it take until these non-pharmacologic treatments take effect? So you can actually see if once you increase energy availability, it alters within days to weeks. It's the recovery of menstrual function that can take a little bit longer. It can take up to several months. So non-pharmacological treatment, that is by far the best route to go around because right now there's just not enough data about medications, which we'll skip over. We'll touch base a little bit about that. So non-pharmacologic, like I said, initial management. So we have treatment for osteoporosis, but it's not for athletes. It's typically for postmenopausal women and some men who suffer from it. So we don't have data to say, put them on, certain medications to see how they do, because there are risks for that. There's also antidepressant medications, SSRIs, that can help primarily in bulimia. And CBT therapy, so cognitive behavioral therapy, has been shown to be effective for those suffering from disordered eating or eating disorders and body image disturbances. Could put them on oral contraceptive, but it's not going to restore the spontaneous menses. It's just going to put a Band-Aid on the problem, and it's going to mask what is really going on. And they also talk about testosterone replacement and leptin as well. There's also the insulin growth factor. So that is an important contributor to low BMD in amenorrheic athletes, but it's still not enough evidence for us to say that would be something that we would start off with. And then it has to be severely low bone mineral density to start with recombinant parathyroid hormone. ACOG came out. This is the American College of Gynecologists, and they came out with using the menstrual cycle as the vital sign. So the strongest predictor of recovery of normal menstrual function in collegiate athletes is weight gain. Again, like I said before, treating it is mostly the data we have is postmenopausal women and men aged over 50. So Z and T scores. So a Z score, what it does is it compares your bone density to the average person of the same age and gender. The T score does something quite different because it's comparing bone mineral density with a healthy 30-year-old female. So it's not really applying to adolescents, since the majority of the athletes that we're seeing. Once again, no published studies for treating osteoporosis. You have these negative side effects with bisphosphonates. They can have osteonecrosis of the jaw. They can get atypical femur fractures, and this is what you're trying to prevent. So a little bit about Dexa. So you have high risk, moderate, and low risk. I have a nice little graph that shows you that. I'll go over in a second. So the decision to do a Dexa scan in an athlete. So the question is, do you do that? Well, if an athlete has a history of more than one non-peripheral or more than or equals to 2 peripheral long bone traumatic fractures that are not stress fractures, you can consider it. Athletes that have been on medication for 6 months or greater that could impact bone, like the Depo contraceptive, oral prednisone. Calcium and vitamin D, that is quite common. Any athlete that I have that has had a stress fracture, I discuss with them the adequate amount that they should be taking. With vitamin D, it should be between 1,500 and 2,000 IUs a day. And then for calcium, it should be between 1,100 and 1,500 milligrams. And a lot of athletes are primarily with vitamin D are not getting enough of that. So that is part of the treatment regimen that I will write for them. So recovery. So the first few days to weeks, you will start to see their energy bouncing back because it's stimulating everything I talked about before in the hypothalamus. And you're slowly starting to have return of those hormones. Over the few months, you'll have you'll start to see some of menstruation coming back. But sometimes it can take up to years regarding the bone, like we were saying, the osteoclasts and osteoblasts to balance themselves back up. So medical clearance. So there's still no standard guidelines for clearance and return to play. That's why it has to be an individualized approach. Here are the different risks. So if we look to the far right, we have the high risk. And that's the eating disorder. Disordered eating meets this certain criteria for DSM, usually like anorexia or bulimia. If their BMI is less than 17, or they have had a 10% weight loss in a month. They had their first menstrual cycle over the age of 16, and they have not had a menstrual cycle. They've had less than 6 and 12 months. And then if a BMD is done, disease score is less than 2. And then you have all the low risk over there. So you add those points up and then you decide, you know, if it's high risk, well, yes, they're restricted. They do have disqualified. It just depends on what the competition, you know, they're competing for, what have you. But usually it's restricted, or they're kind of put aside a little bit till we can get everything else cleared out. So provisional return. So I'm going to just go back to this basketball player that had lost a good bit of weight. So here again is her screening questionnaire. So we did begin some treatment. She did score 4, so just going to take you back here. So we know it's, and if you look at the moderate risk, she did have dietary restrictions, so she gets a point for that. Her BMI was normal, so she doesn't have a point for that. She does get a point because she did have delayed menarche, so that's 2 points. And then if you look over at the high risk, she had not had her menses. She had less than 6 menses in 12 months. So that's another, that's 2 points added on. So we're going to go back to the fact that she scored a 4. So what did we do? She actually did really well with a diary log where she was writing down her food. Now, we are trusting that she is writing down appropriate food, but she did have some roommates who were very helpful and supportive, which made a huge difference. We had weekly weigh-ins. She did not look at the scale. She saw a sports dietitian and the school psychologist. We were very fortunate that we were able to have both of these consultants available to us. And then we supplemented with vitamin D, calcium. She started taking a multivitamin, doing protein shakes. She checked in weekly with her athletic trainer and then the physician every 2 weeks. She gained about 12 pounds back. She was definitely had more energy, was looking at food more as fuel than as something that's gonna inhibit her or make her feel a certain way. And she ended up performing really well. The surfer. So he was evaluated weekly in the clinic. A sports nutritionist was referred to him as well, and that helped to break down certain types of food without doing the intermittent fasting or juicing. He actually, there's a counselor specifically for surfing out there that he was able to speak to because of the variety of surfing methods, and that what he picked up with the hydrofoiling, so that helped him a lot to talk through that. Supplementation, again, same thing, vitamin D and some calcium. And then he actually did some cognitive behavioral therapy. And then he slowly reduced doing hydrofoiling. He would get out there just swimming first, then paddling out, then getting up on a board. And then there was also, we did a treatment contract, just essentially breaking down step by step what he was going to do so he could see short-term goals and long-term goals, and sign that that was what he would do, and that worked well for him. Not everyone will respond to that. So that's why I keep saying it's got to be individual. He did gain 10 pounds back at that time over, it was about 2 months time that he gained those 10 pounds. He definitely was in a better mood, and he went on to win multiple competitions through Maui and Hawaii in the North Shore, but he ended up transitioning to longboarding. So both of these, there was good outcomes based on very individualized protocol that we built for each athlete. So we have what the physician's duty, but really this is the duty for anyone in the medical field that works with athletes. So we want to return this injured or ill athlete to practice competition without putting them at more risk. Establish a return to play process. And like I said, there are no standardized tools to say all these athletes need to go through ABC, kind of like similar to what we had initially with COVID clearance, you know, oh, they have to do these 7 days. This is the return to play protocol. It's got to be very individualized because not everyone's going to respond the same way. Some athletes have other medical conditions. Some are already coming in with iron deficiency anemia. Some have depression. Some came earlier, you know, maybe in middle school with bulimia. And then returning the athlete to play once we know that it's safe to do so. So again, some medical factors, you have to take in some sports risks, and then decision. Are they in season, out of season? You know, what else could be going on? What is extremely important, and I have learned over time, is just gaining that mutual trust. So especially for myself and team physicians who do not see the athletes as frequently as athletic trainers, we have to establish that we are there to help. We are not there to stop them from doing what they love and playing their sport, but we need to make sure that it's done in a safe and healthy way for them to get back to that optimal, you know, peak performance. And knowing that it's a group effort, personal interviews are much better than just screening tools, although I know that is quite time consuming. There are some questionnaires which are in development that aren't quite out there yet. This is directed towards women, about women, but this is Mary Kane. She had said, talking about a toxic coach-athlete relationship, just saying she was just caught in this system, destroying bodies. And it says young girls, but it's also for men as well. And we need to take this multi-centered approach. This is kind of like the SCAT, but it's for relative energy deficiency, and it just tells you, okay, green light, you can go, just breaking down, you know, all of this stuff. The moderate risk is where we're mostly going to see our athletes in. And that is all. Thank you. Let me stop sharing.
All right, awesome. Let me go ahead and change this back. Okay, so our first question is coming from Kyle, and Kyle is asking if what are the concerns with utilizing Dexa for younger individuals and the exposure to radiation, and then as it compares with the need for the information, even if the radiation exposure risk is small?
So that's a good question. So yes, the radiation risk is small, but the risk of them having more stress fractures that could turn into pathologic fractures is much higher. So typically the Dexa scan is a PA of the spine or of the femoral neck of the hip. So yeah, you're getting majority of the core which you're scanning, but we're not doing, I know I haven't done that many Dexa scans. It hasn't driven me to do that quite yet, but there has to be everything else combined. You have to have seen, they had to have had multiple fractures, having this weight loss, you know, not just the poor performance. So I would say for the Dexa, when you have that high risk, it's gonna outweigh, you know, the benefit of getting the Dexa is gonna outweigh the risk at that point as far as radiation.
Okay. And if anyone has any questions, I am happy to go through those. Aside from time here. We had a great turnout, certainly.
Yes, thank you everyone for being here for this.
Michelle says thank you.
And if anyone has any questions after, I believe Dr. Hanita will be a way for them to ask or get a hold of us, maybe potentially, or any in particular with their own athletes.
Denise said, great lecture. Oh, here we go. Okay, this question comes from Morgan, and she asks, do you have any recommendations for easy, and that kind of is in quotes, easy ways to increase calories for athletes?
So I found with a few of the athletes who are on the go and aren't able to, you know, take in the appropriate amount of solid foods, a lot of them are shakes, using the protein shakes, the, you know, appropriate ones. Some of them like to put, you know, the peanut butter and what have you, mixing that up, and that way they can have it on the go, and also allows them to be able to go to, you know, their practices and not cramp up or anything, or have a certain amount of time to digest it. So I would say that. I have had some athletic trainers who actually have blenders in their break rooms and stuff, to the athletes will just bring all their stuff and blend it in there to make it a little bit easier for them.
Great. Craig says, thank you, very informative. I'll give it another minute or two. There are, I see a good amount of some local athletic trainers here, and some of our regular attendees. We've got some of our team on the line. I saw O'Reilly's on here.
Hello, O'Reilly. Thanks all for joining. I hope there was some information that was new for all of you.
I know that sometimes at the end of these things, when I'm trying to plug in questions, it's like, hold on. Don't finish.
Don't close out.
Yep. I'll give it another minute or two in case anyone has any of those last minute burning questions. Let's go ahead then and wrap it up. So thank you so much to Dr. Nicoletti tonight for joining us, for giving us this great presentation on relative energy deficiency in sport. And now everyone else gets to see her, meet her, maybe for the first time, maybe you worked with her before. As part of Relevé Sports Medicine, she just joined us a couple months ago, and so we've been so thrilled to have her as part of this team working together, getting to take care of Polk County athletes. So thank you to everyone for coming, and thank you to Dr. Nicoletti for putting together a great presentation.
Thank you for having me, and thank you for everyone for coming and joining us tonight.
All right. Have a good night.